All right, thank you very much. It's a real privilege to be here, and it's always an honor to do this at Sages because of their support from the military in the past. These are my disclosures. I was just complaining about how much I weigh, so this may be one of the reasons why. All the industry pays me in food, and I gladly take it. All right, so some of you may not be familiar with the nomenclature, but one of the ways that we work on the battlefield, or I shouldn't say we, but when the military works on the battlefield is by identifying levels of care. So level one in the U.S. nomenclature is the closest to the battlefield. They're like the battalion aid station. Level two is the forward surgical team when they're designed to do life-saving surgery, so damage control, life and limb-saving surgery. And level three is kind of like the old cash or MASH hospital, so more resourced, more people, more security. The NATO equivalent is role 1, 2, and 3. So you'll hear those terms being used interspersely, but they mean the same thing. It's just the U.S. has to have a different nomenclature, as you guys all know. So what does it mean again? So the level 1 or role 1 is the on the battlefield TCCC care, so tactical combat casualty care. Tourniquets, maintaining your airway, fast evacuation either by an ambulance on land or by a helicopter. And then this is there to meet the golden hour. So these forward surgical teams will be deployed really just a few kilometers from the battlefield so that the helicopters can get there, or the ambulances get there within an hour. So when they do medical planning and they talk about combat operations, they will move these forward surgical teams every few days or every few weeks to be where they think the fighting is going to be, so to better adapt, to better be able to intervene for the critically injured. And then within 24 hours of that event, another transport will get that patient back to the combat support hospital, which is really a fully fledged hospital. It just happens to be in the combat zone. So there will be CT scanners, ICUs, med-surg beds, as well as ICU beds, different specialties, et cetera, to take care of the patient. And then eventually they'll be evacuated out of the combat zone, which is level 4 care. So in this case, in Iraq and Afghanistan, they went to Germany. And the further you go back, the more safe you were typically. So this, again, it requires a reliable evacuation system. It requires a secure level 2 or role 2 facility and a better resourced level 3 facility. And with that, we've had very good success over the last 20 years in war. So the gold line going up is the number of casualties. The light blue line, so the dark black solid line is the casualty fatality rate, which is right around 90% and has been coming down since the beginning of the war. Our died of wounds rate also is pretty good and been maintaining overall a lower level, which means if you get hurt and you're not killed right away, you're able to survive with the interventions that the evacuation system has provided. Again, this is what we do. This is what you would typically do in a situation like an IED blast to an extremity. You'd splint and tourniquet it to stop the bleeding. At level 2, you would do more surgical maneuvers to control the bleeding. At level, you might shunt or exfix something at that time to control the bleeding. At level 3, you might consider doing the fem-pop bypass at that time versus an amputation, depending on what was left. And then they were going to get multiple washouts when they're in a cleaner facility, so you wouldn't likely close the wound completely in country. You'd wait till they get out of country. A couple years ago, we presented this gentleman, Major General Daniel Walrath, from his injury. Some of you met him a couple years ago. This is how I met him in 2012. He had stepped on an IED and suffered significant damage at the roll. They actually had a half FST out there, and that surgeon basically tourniqueted and splinted him. He got evacuated to our more fully capable FST, not fully, but more capable FST, where we took him to the operating room and shunted his popliteal artery and exfixed his leg. And then he got to Kandahar, where he got his bypass by a vascular surgeon. And then 32 operations later, washouts and debridements and such, he got fitted with a prosthetic device and stayed on active duty. And even completed the Army fitness test and ran the Army 10-miler before he finally retired around 2002. So the bottom line is we've had some pretty good success with this. He had 3 operations within 24 hours, as well as 3 evacuations. It results in our casualty fatality rate. and also about 5,000 deaths in the 18 years we were at war in Afghanistan and Iraq. The benefit of having air superiority is no one is shooting you down. There's no opposing air force, so Iraq and Afghanistan did not have those capabilities. And their weapons were relatively short range, so within a few kilometers as far as our mortars would go, they did not have long-range missile capability. But that's different with a near-peer adversary. And what I mean by that are those two flags you see right there. I'm not trying to hide that fact. It's China and Russia. This is not a political message, I promise you, but they do have military capabilities that is equal to ours. So they do have air forces. So if we were in combat against them, our air medical evacuation would be compromised. They do have long-range capabilities, so their missiles can fly all the way across the country and hit places that are very far away from where they're launched. Now, that doesn't mean that the patients still don't need what they might need, but that does mean that your facilities need to be better resourced the further they go out and better secure. So this is Ukraine, and you can see where Kiev is in the middle, where most of the fighting was in the beginning of the war, and then you see where Lviv is on the far left-hand side of the country. This is about the distance from New York to Chicago, so it takes a fair amount of time to get across the entire country of Ukraine. When we were there in February or March of 2022, we were in Lviv, which is here in this little shorter film on the bottom right-hand, and a military base was hit near the Polish border, which killed 32 soldiers at that military base, and that was launched probably from Belarus, although the Russians claim it was launched from inside of Russia. But nonetheless, it was a far range that they were able to cover. So from that experience, we published this paper in JACS, and admittedly, it is personal experience. It's not a robust database, but we did have a special forces surgeon who was on duty and role in the thick of things, who was providing us the bulk of our information, as well as the people on this paper who had actually been personally in Ukraine during the time of the conflict. And again, their conclusions were kind of the same. The threat scope is much broader. You were not able to achieve airspace dominance. There was a significant threat to healthcare providers if they were to come close to the battlefield, and even if they moved further away, there's still a threat. And this paper, came out in March 2022, as you can see, so just about a month after the war, and by then 10 hospitals were already destroyed. So they were not picking out the military targets to fire at, they were going after all the hospitals. So what we thought should be 1 hour or 1 to 24 hours for 2 evacuations now became closer to 2 to 4 days, excuse me. And so from there, borne out the use of laparoscopy and thoracoscopy, on the battlefield, right? Because you didn't have a CT scanner out in the Role 2 area. You didn't have long-term capability to observe. And so you had to have a way to make sure these patients didn't have injuries that were occult from their initial evaluation. So what patients does this represent? Well, I can think of 3 kind of off the top of the bat. Stable patients, first of all, with penetrating lesions to the chest or the abdomen, and then head-injured patients who have an unreliable exam after blunt surgery who might need something done. You heard last year, Dr. Popova present on her data for the ultrasound adaptation. So she added 3 more examinations during the ultrasound so they could identify injuries to the cecum, sigmoid colon, and the retroperitoneum. And we're waiting the data to come out from that, but their thoughts, if they see abnormalities there, that they will operate on those patients if they're stable. And hopefully the space, yep, it's playing. So this is something that you might see, right? This might be a positive fast scan in this case, but stable. But you see a pretty good sized missile that's in the liver here. This came from an IED blast that penetrated this patient and then ended up in his liver. Now, for the use of trauma surgery, this actually isn't a new concept. In SAGES of 2022, SAGES member at the time, Colonel Matt Ritter, described a similar instance where he removed a missile from a soldier who had stepped on a blast and it went up through his leg and into his pelvis. They saw it on ultrasound and proceeded to laparoscopy to take it out. The aforementioned Kurlan Gumenik is currently doing some of that now. And during the military session, you heard Dr. Danetz from the Ukraine surgeon talking about that. And his work won the Admiral Robinson Trauma Paper Competition. It doesn't apply just to trauma surgery. MIS, emergency general surgery, is also needed in situations. And again, all the benefits of MIS approach would be there. You can imagine if there's a hernia and you can fix it laparoscopically, that patient can get up and move around and evacuate better. So this is one of the cases that I did when I was over there. And this is also not new. So in 2011, Commander Pearl presented his data. Now, he was at a level 3, so it was a little bit different, but you can see that he was pretty busy, and these patients all could return to duty. And from this paper, he decided to do a more robust study, not just a case series, but he enrolled patients and did a fast-track hernia protocol. You can see they're relatively young people and probably in shape because of the military, and his protocol was have them return to duty in 3 days. Now, contrary to belief, not every person who's on duty has to do infantry type work or heavy lifting, but they're still pretty active, but they could be returned to duty in 3 days and not be evacuated for their hernia repair. And so he was pretty successful doing both TEPs and TAPs in that situation. However, there is a gap, right? You just can't carry all your equipment all the time. There's some safety issues with it. This is another SAGES member, one of our scheme panelists here, who took the SI robot on the USS Mercy over to Sri Lanka and did some cases there. But as you can imagine, that's a pretty bulky endeavor to do that. So in summary, I think MIS surgery in combat is sort of born out of necessity because you just can't evacuate people as quickly. And the patients do need to return to duty. So there will be an increased role for it. I think it is, back up. I think it is feasible in that environment. But again, they have their own challenges. I've only been talking about a land war. If China were to get involved with something in Taiwan, again, not a political message, then we'd have to adjust for maritime capabilities as well. And the possibility that, again, there's going to be a very long-range weaponry involved. That is the end of my talk. I thank you for your time.